Prakash, are the cases sorted now then?
Yeah, cases are lined it up. That's what it depends on how much time we get to spend. So
Sure.
I've lined cases 1, 2, 3, 4, 5.
Depends on how much time we get to spend.
Okay, welcome everybody. We are live now, and I hand it over to our moderators for further proceedings. Over to you, sir.
Thank you, Ashok. Welcome everyone. It is my pleasure to host the Young Adult Hip Symposium organized by the Northwest Education Academy and broadcast live on OrthoTV. We have an eminent faculty today, and you will hear from Mr. Adi Bonshahi, Professor Tim Board, Mr. Ajay Malviya, and Mr. Prakash Chandran. If you have any questions, please use the chat function, and you can also email us on northwesteducationacademy@gmail.com. If I can ask Mr. Bonshahi to share his first slide. Mr. Adi Bonshahi is a consultant orthopedic surgeon at Pennine Acute Hospitals in Manchester, and he's an honorary senior lecturer at Edge Hill University. He provides a tertiary referral service for hip arthroscopies, complex primary and revision hip surgery, and he has developed a modified anterior hip approach for primary hip replacements. He has numerous presentations and publications to his name, and without much ado, I'll ask good friend Adi to start his presentation. Adi, over to you.
Yeah, thanks, Nikhil, for the introduction. And today I'm going to talk about a couple of soft tissue hip disorders in which I feel surgery can be beneficial. So I work in the Northern Care Alliance in Manchester, and it's one of 5 hospitals with a fairly large orthopedic department and a fairly large population, not by Indian standards, but by definitely UK standards. We serve about 1 million population, doing a large number of joint replacements. And I'm one of 2 hip arthroscopy surgeons there, apart from my interests in revision hip and primary hip arthroplasty. So today's talk is going to be mainly about post-total hip replacement psoas snapping and groin pain as a result, and also a very common lateral hip pain produced by gluteus medius insufficiency or deficiency. And mainly I'm going to focus on what we can do surgically as orthopedic surgeons in these conditions. I will speak about a technique of Lars reconstruction that I have developed and the results of the same, and we'll take questions at the end. So to begin with, we know that hip pain can be from intra-articular pathology with groin pain, but soft tissue causes can also cause groin pain, such as internal snapping from the psoas tendon, which can be native as well as from the total hip replacement. Lateral hip pain is one of the common presentations in clinics, which is a bane of most orthopedic surgeons. We call them trochanteric bursitis, but it's a misnomer. They can be anything from medius tendinitis, medius tears, ITB snapping. We also know gluteal pain can come from a variety of different conditions, including the lower back. So the 2 conditions I'll talk about is the psoas tendinitis from the native hip is not what I'm going to focus on. I'm going to focus only on the post-hip replacement psoas tendinitis and snapping, and the chronic lateral hip pain. We'll talk about it a bit later. So what is this condition? It is seen in about 4.3% of cases following a hip replacement in those patients who have hip pain. It's very important that we rule out all other causes for pain before we come to this diagnosis. And there are a couple of investigations which I'll talk about how we come to this particular diagnosis. And typically patients complain about deep-seated groin pain a few months after their hip replacement. It's not immediate, because immediately they feel relief of pain, the arthritic pain from the operation. But usually a couple of months, 2 to 3 months later, they complain of this deep-seated groin pain associated with clunking or grinding sensation on certain movements. And this circumduction is nothing but flexion, external rotation, abduction, and extension of the limb. They typically complain of startup pain, especially whilst getting out of a seated position, pain on climbing stairs. And sometimes some of them have got so much weakness that they actually have to lift the thigh when they are seated to get the limb off the chair. On examination, there can be not many specific findings, but you look out for deep groin tenderness. You can feel the click or clunk sometimes as they perform that movement. And if you press directly on the iliopectineal eminence or deep in the groin, you can sometimes stop that click from happening. Pain on resisted flexion in a seated position is sometimes positive for psoas snapping or psoas pain. But there is no pathognomic test. Investigations of plain X-rays may or may not show any significant abnormality. You have ruled out other causes of pain. Sometimes it is seen in patients where you have reduced anteversion, especially if you've done the operation through a direct anterior approach or the Harding approach. And it can be seen also where the cups are closed. So these days, we all aim for 35 to 40 degrees of inclination because of the hard bearings that we use. But as we start closing the cup, it is very easy for the anterior edge of the acetabulum to sit proud of the anterior wall. So you need to be careful and dial in a degree of anteversion when you do that as well. Lateral X-ray may show acetabular overhang anteriorly. CT scan may show this prominence, and it's important to get the CT as a basic requirement for these patients. It does not have to be a significant prominence. Even a subtle cup alignment with the anterior wall can cause psoas impingement, especially at the psoas groove area. So if most hip arthroscopists will know what the psoas groove is because you can see it. But the next time you do a hip replacement after you excise the labrum, if you run your finger just on the anterior wall of the acetabulum around the 3 o'clock position or a bit more inferiorly, you'll feel a slight depression in the acetabulum there. So it is not uncommon that even if your cup is lined up perfectly well with the anterior edge of the acetabulum, you may still get impingement. Ultrasound-guided injections is the most useful investigation, and actually it is the diagnostic investigation in this case. We get them done by the radiologist. MRI scans can be done, but it's not very useful. If you get an MRI scan, it's best to get the metal artifact reduction scan, and you may see some fluid around the psoas tendon, as in this case. So what can be done for these patients? Obviously, the first line of treatment has to be conservative with physiotherapy and stretching. Ultrasound-guided steroid injections by the interventional radiologists is a good option, but you need to stress on them to get them done under sterile and aseptic precautions. The worst thing that can happen with the steroid injections is you may get attrition rupture of the psoas tendon, which is actually what the surgery does. So it may relieve the problem the patient experiences. Surgery should be considered after about 6 months of conservative trial. So what are the surgical options? The main thing is whether we should revise the prosthesis or do something else with like an arthroscopic release. I would only recommend revision if there is component malposition. And there is one paper which suggests that if there is a cup prominence more than 8 millimeters, one should consider revision. For all other cases, you have to weigh up the risks of revision versus, a more simpler operation of an arthroscopic psoas release. So what is the technical challenges in this procedure? One of the important things to note is that you're actually going around the front of the trochanter down to this junction between the head and the trunnion, because there isn't actually a space into which the hip can be arthroscoped. Most of it is scarred down anteriorly from the operation, and there isn't a true joint space. So you can't distract these hips. It's done through the peripheral compartment. The portals should be lower than the normal hip arthroscopy portals. And sometimes it can be as low as this to get to where you need to go. And essentially what you are aiming is that you get into this pocket of space and then place the second portal in the same pocket where you get a bit of visualization and then work your way over the head towards the 3 o'clock position on the cup. And the images you kind of see are something like this, where you see, this is the ceramic head. There's a lot of scar tissue, and you just have to work your way using your arthrovond and shaver. Ultimately, you come across the psoas tendon, which I find that, it can be pigmented. And as you release that area, you will get a bit of brownish fluid coming out, which is from the tendon sheath. So the results are actually very encouraging with the arthroscopic release. It's a very successful procedure with one study showing about 92% success rate when you compare it with the open procedure. But the most important thing is that patients should remember that they will have difficulty in getting in and out of the car because there will be noticeable weakness in deep flexion beyond 90 degrees. So that is where you need to counsel these patients beforehand before you proceed with the operation. So to summarize, you can use this kind of algorithm to rule out other causes of the hip pain, consider diagnostic hip injection. If there is pain relief, you look at you trial conservative treatment for about 6 months. If there is component malpositioning, consider revision. If there is no malpositioning, arthroscopic release. So to summarize, it's there. This is a condition that does exist, and if you're aware of it, you'll pick it up in your outpatients. Diagnostic ultrasound-guided injection of the psoas tendon sheath is the test of choice, and consider arthroscopic release when conservative measures have failed. What is important is that you can actually prevent this in your primary hip replacements. Number one, by avoiding a more neutral anteversion, avoiding a closed cup, respect the psoas groove area, which is this sort of area in the anterior acetabulum, and check that area specifically after you've implanted the trial as well as the actual prosthesis to confirm that there is no overhang there. The next condition I'm going to talk about is the chronic lateral hip pain patients. And these have been misdiagnosed as trochanteric bursitis for a long time. But very often we find when you scan these patients, they have underlying gluteus medius tendinitis or tears. And tears of the hip of the medius is actually quite debilitating. Much like the rotator cuff of the shoulder, it is quite debilitating for the patient. And you can have de novo tears because of degeneration of the tendon, or you can find these tears in patients who have had the lateral hip or approach or Harding approach to the hip. So they have troublesome lateral hip pain. They've often gone from pillar to post, multiple hospital visits, and eventually they come down to a tertiary referral center where they have got this type of difficulties, unable to sleep on the affected site, previous hip replacement, multiple injections by their GPs. So what do we look for? You may have a positive Trendelenburg test. You will have some tenderness over the trochanter where there may be some weakness and abduction. But what I specifically look for is this kind of image. I hope you can see the video where they have weakness and abduction. You passively then abduct even more and then warn them that you're going to let go of the leg. And you'll find that the leg kind of drops down in those large tears. And that is quite useful. I call it the drop leg test, bit like the shoulder drop arm test. So plain x-rays may not show anything abnormal. The MRI scan confirms the tears. In the scan, you should also look for atrophy of the muscle. Now, there will be, in any chronic tear situation, there will be some atrophy. And you know, what you have to look for is complete loss of the muscle fibers, which I've not come across yet. So how do we treat this? Further injections obviously is not effective, and it is detrimental because this may be one of the causes why the tendon is undergoing tear. Surgically, Repair is not beneficial because, the tendon is itself degenerate. So even if you put sutures through it, it's going to pull off and cut through. Reconstruction is the better option, where you augment the repair with some sort of ligament or artificial substance. And in those who have got complete atrophy or complete loss of the muscle, consider the Whiteside procedure described by Leo Whiteside, where he transfers a bit of the gluteus maximus tendon. I haven't done this procedure, but I think Tim has. Counseling is very important because this is not a procedure of choice. It's a last resort treatment. They have to understand that the results are variable. It will never make them hips normal. It will make it better, but not normal. And as long as they understand that, it is a good option to consider. So what do? I use this ligament on the right-hand side. It's a Lars ligament. Basically, it's made of Dacron with two coattails. And we sandwich this between the medius and the minimus. So I did 8 patients up to 2017. We've done a few more after, but I've not captured that data. And you can see it's not common really. 8 patients over a 5-year period, is 1 a year or 2 a year, but you have to be very careful in selecting these cases. So 5 of these were native hips. 1 was a total hip and 2 revision hips. They all had a demonstrable abductor weakness, and they had MRI scans that confirmed the tears. So what we find at surgery is this: you find the ball trochanter, and there is the torn tendon. You may find that the posterior edge of the muscle is intact, and that is quite commonly seen. The anterior part is completely denuded, but the posterior couple of millimeters of tendon may be intact. So you dissect out the medius tendon from the minimus below and the ITB above, and you can actually pull this down. And in this case, you can see the muscle is not bad, bit of fatty infiltration, but you can see the muscle fibers look healthy there. After that, you insert the Lars ligament, which is actually designed originally for the rotator cuff tears, and you put it underneath the medius, and you repair both to the tendon and to the muscle, some interrupted sutures through the muscle. But all goes from below and between the 2 muscles. After this, you freshen the greater trochanter down to bleeding bone. You insert 2 tunnels, transtrochanteric tunnels, and then you insert the coattails of the ligament through those tunnels and tension it at about 20 degrees of abduction and 10 degrees of internal rotation. So kind of post-op X-ray you see is something like this, with the 2 interference screws in the transtrochanteric tunnel. And in one patient, we actually she had problems on the other side. So we had managed to get a post-operative MRI scan. So you can see pre-op, there's the tear there, there's an atrophic muscle, and in post-op, you can see the muscle is reattached. There is a better bulk of gluteus medius in the post-operative scan. So the results were fairly surprisingly satisfactory. There were 8 patients, all over the age of 57. We had a good post-operative follow-up. Important thing post-operatively was to weight bear them straight away with crutches, but with a shoe raise on the opposite side. And that is to tilt down the pelvis down the surgical side, and it produces a functional abduction and relaxes your repair. So out of the 8, the 5 patients actually regained abduction of the limb. And that was not seen in the 3 remaining patients, but they did have improvement in pain and ability to sleep on the affected side. All of them improved in terms of their Oxford scores, both in the patients who were native hips as well as the arthroplasty hips. And to summarize, this is a difficult condition to treat. You have to have a high index of suspicion in patients with chronic trochanteric bursitis. It is a last resort treatment. This is the same patient we saw earlier who had bilateral symptoms, and she's got a scar there. You can see this was one we repaired, and you can get abduction back like this, and they can control it very well. And we have seen satisfactory results so far. Thank you. Any
Thank
questions?
you, Adi. That was a really enlightening talk on two very difficult problems, which I think about 5 years back we ignored and said there's nothing much we could do about. So thank you for that. If I may ask one question that has come up is what is the percentage of total hip replacements that have these kind of soft tissue impairments in general? Is there
I mean, it's not common actually. You know, first you have to ask yourself is how frequently do you see a patient with postoperative persistent post-op pain following a hip replacement? It is not frequent. So in that study that I quoted, actually, they looked at about 100 odd patients who had postoperative hip pain. And of those, only about 4 to 5% had psoas impingement. So it is not a common condition, but it is something that you keep in the back of your mind to exclude, to consider once you've excluded all other causes. But we see, I mean, I haven't seen actually a larger number of these referrals coming through, but that maybe because, you know, we are only two of us doing hip arthroscopy where I work. And it may be also that we are doing now a greater number of cementless cups, and with the rigidity of the acetabular shell, you are seeing this more frequently, I feel.
So yes, that was the other question is this problem, especially the iliopsoas problem, more common with cemented or uncemented cups? And is there something that you specifically do after your hip replacement, say run your finger over the anterior edge to see that you're not impinging? Is there something that like that you do?
Yes, I do that. I do that in all cases. And then I put a Homan in that antero-inferior area to just visually check and feel that I'm not overhanging there. So yes, I would say it is more common with patients who have the cementless hip. And in the series that I had, they were all cementless hips. But I know Tim has had one where there was cement extrusion. But I just feel the anterior poly flange is much more softer than a rigid metal shell. So it is more common, I believe, with the cementless acetabular.
Wonderful. Thank you for that, Adi. I think with our time restrictions, we'll move on to Tim's presentation. Tim, do you want to get your presentation on, please? If I can introduce Professor Tim Board, it is our pleasure to have Professor Board on our faculty today. Professor Board specializes in complex primary and hip revision surgery at Wrightington Hospital. He holds a MD in research in bone grafting and an MSc in orthopedic engineering. He chairs the British Hip Society Research Committee, is on the executive board of the British Hip Society and the Northwest Surgical Trials Center. He has numerous publications and has written book chapters. He has research collaborations with the universities of Manchester, Leeds, and Salford. And it gives me a great pleasure to invite Tim on behalf of the Northwest Education Academy to give his talk. Tim, over to you. Tim, you're mute.
I couldn't turn off mute when my screen share was on for some reason. Apologies, everybody.
Not a problem.
Okay. So thank you very much for asking me to talk today. So I work at Wrightington Hospital in Lancashire, the home of Sir John Charnley. And I'm going to talk about femoral acetabular impingement, how to identify it, what the treatments are, and perhaps most importantly, how to pick the winners. So what is FAI? So FAI is a repetitive abnormal contact between the femoral head or neck and the acetabulum, and this leads to damage to the labrum and to the hyaline cartilage inside the hip, mostly in the acetabular side. And it leads to pain, and it leads to limited function. And it's caused by an abnormal shape of the femoral head-neck junction, and also sometimes of the acetabulum as well. And it was described by Reinhold Ganz, and the classic features of the cam and pincer type of morphologies. Now, if you've not been quite sure what a cam is, you know, the engineering people amongst you will understand that a cam is a part of an engine on the camshaft, and as it rotates, it pushes the tappets up and down, which let the exhaust gases in and out of the cylinder. So as you can see here, this is a cam shape, and as it rotates, it pushes against something. And that can be translated into the hip with this animation that I hope is running okay. You can see the cam shape in the hip, and in flexion, that isn't able to push anything away, so it produces compression forces, abnormal compression forces, at the anterior superior aspect of the acetabulum. And with repetition over time, that accumulates into damage, mostly in a pure cam, in damage in the acetabular rim and the weight-bearing cartilage. And often the labrum, whilst it can become torn, the attachment often does remain intact. And over time, that produces these typical wave signs and delamination of the anterior superior acetabular cartilage. And these are the typical morphologies: the normal, a pure cam, a pure pincer, and pincer is an over coverage of the acetabulum, which can lead to impingement of the labrum on the femoral neck, and then the mixed variety when there is a bit of both. This is just a surgical video, so it is possible to treat these through open surgical hip debridement, and this is a little reshaping tool, and you can see this is a hip dislocated, and as we use this tool over the head, you can see that it's lifting off the femoral head. So if you imagine that was the acetabulum, you know, it wouldn't be subluxing the head out of the acetabulum, but it'd be causing really high stresses in the front of the acetabulum. And then after reshaping, you can see the exposed bone there. After reshaping, we can bring that tool much further around, so that then when the patient will be flexing and internally rotating their hip, they won't be suffering from impingement. So how do these present? Well, Adi's already told us about the C sign, and this is quite typical, that the patients will use their hand and say the pain is deep inside the groin, kind of between the fingers. It's commonly a new onset pain, absolutely activity related, certainly in the early stages. And if there is significant damage to the cartilage and the labrum, then you can get clicking, catching, giving way, and other mechanical symptoms in the hip. Examination, it's always really important in these patients, particularly the sporting patients, to rule out a hernia or a sportsman's hernia. So palpation over the inguinal ligament, particularly medially and slightly above the inguinal ligament. If that's painful, then I'm a bit suspicious. But if the pain is inferior to the inguinal ligament, it's more likely a hip problem. In terms of range of motion, obviously you're going to perform a full examination of the hip, but typically the patient would lack internal rotation in flexion, and that's the real key feature. And the impingement test, which is a combination of flexion, adduction, and internal rotation, will commonly precipitate significant pain. Now, other movements of the hip may also precipitate pain, but generally the Fadir test will produce the most acute pain. So quickly moving on to investigations, I think this is really important because we're increasingly seeing lots of people whose first line investigation has been an MRI scan, and they've skipped the step of a plain X-ray. And as orthopedic surgeons, we always want to know, what the anatomy is like before we start thinking about the soft tissues. So the plain X-ray is really important to start with that, and a full pelvis X-ray. A lateral X-ray may or may not be helpful, but the X-rays are really important to exclude other problems such as osteoarthritis, dysplasia, and avascular necrosis. So here's a straightforward AP pelvis X-ray, and you can see I've marked on here a center edge angle, because I think that's almost one of the first things that you should do when you have a patient with hip pain, is to ask the question, is this dysplasia? And I will talk a little bit more about that further on. Here's another X-ray, and you can see there is an asymmetry of the femoral head-neck junction in this hip. If we draw a circle around that head on the right compared to the left, you can see here that there's more bone outside of that circle in the neck region, and this is the cam area. On a lateral x-ray, you can do the same. So you draw a circle around the head and you can see the bone anteriorly, which is outside of the normal head-neck junction area. And we can measure this with what we call the alpha angle. So it's the angle where the bone is outside the circle and the angle that subtends with the femoral neck axis. And that would normally be less than 55 degrees. And you can see here that it's approaching 90 degrees. So that's obviously very abnormal. You can also measure that angle on a CT scan as per the image here. So having understood the anatomy to a certain extent with plain x-rays, it's then reasonable to move on to further investigations. So we would commonly do an MR plus or minus an arthrogram, depending on the sequences, the quality of the scanner and the intensity of the magnet that you have. And these can clearly show a labral tear well. And you can see the picture here, that's a pretty clear and obvious labral tear with the dye in between the labrum and the anterior rim of the acetabulum here. And also you can see that the actual signal of the triangular labrum here is very different to the signal of the labrum posteriorly. So there's a degree of degeneration in this labrum. But the problem with labral tears is that you can have a really high incidence of incidental tears. And I quote to patients, up to 2/3 of patients can have, a labral tear which is not causing pain. So it has to correlate with the symptoms. So it's a little bit like all degenerative processes, your MR scans of the shoulder, high incidence of asymptomatic cuff tears. It's the same kind of problems. So don't over rely on this. Now, because the three-dimensional anatomy of the hip is so important to the etiology of impingement, it's really important that you understand that. And the best way to understand that, in my opinion, is a CT scan with three-dimensional reconstructions. And that really allows you to understand not just whether or not they have a cam, but where that cam is placed. Where do I need to address? Where do I need to reach with my surgery if I'm going to do surgery? Is it amenable to surgery? This image at the bottom of post-Perthes, probably is not amenable to surgery. There's nothing you could do to that hip to make it a normal shape. And that has to be the goal of surgery. And it's also really useful for ruling out early osteoarthritis processes. I find OA easier to rule out on a CT than on an MR, and I'll show that a little bit later on. And diagnostic injections can also be really helpful for these patients, and that can also form part of treatment. So the treatment, as with everything, it starts with conservative treatment, absolutely, and a really experienced physiotherapist to assess and treat the patient, largely focusing on core strength and hip girdle stability. A diagnostic or therapeutic injection can be really helpful. Sometimes these patients have quite an irritable hip and they just cannot engage with the exercises. So to give them an injection which will settle their inflammation for a period to allow them to improve their core stability and strength, and then they will have the stability to not get further problems in the future. And obviously we would consider surgical treatments only if conservative strategy has failed. And actually in femoral acetabulum impingement, there have been two recent randomized controlled trials of surgery versus physiotherapy, both done in the UK. I won't go through these in great detail, but these are the sort of the main outcome graphs, the FATE trial from Oxford and the FASHION trial from Warwick. And they've both shown that patients in both groups do improve, but there is a statistically significant and just about clinically significant difference between the physio and the surgery groups. And you can interpret this how you will. The issue with surgery is that surgery has risks of complications, and complications were seen in both of these groups. Whereas physiotherapy, my view is the worst that can happen is that it doesn't help. So I would always offer my patients physiotherapy first, and then if they're not satisfied and they're not happy, then I'll be happy to offer them surgery. So what is the surgical treatment? Well, it's twofold. One is obviously to repair the soft tissue damage or debride the soft tissue damage, because that's what's causing the pain. And also to try your best to correct the underlying bony abnormality so that it doesn't progress again and return in the future. But also we need to be aware of other contributing factors, and that can be femoral and acetabular retroversion, and also ligamentous laxity. What do we do in the surgery? Well, obviously we would repair the labrum if at all possible, and do any other treatment that we can within the central compartment of the hip. And then we move to what we call the peripheral compartment, which is essentially when the hip is no longer distracted, and then you move your instruments over the anterior aspect of the hip. And this is where we're looking now. So this is looking down onto a cam area, and you can see the high-speed burr is just slowly removing and reshaping the femoral head neck zone. And we're trying to remove the bump to improve the range of impingement-free range of movement. So what about picking the winners? You know, who does well? Well, I think probably all of my colleagues here today that do this kind of surgery would agree that the young male with a really obvious cam who has a short duration of symptoms is the most likely patient to do very well over the longer term. And the negative, the other end of the spectrum, is the patient with osteoarthritis. And you might think that I mean, you know, bone on bone changes, but actually the more cases I've done, the more rigorous I've got at excluding patients with osteoarthritis. So essentially, if I can identify any arthritis, then I would likely not do the surgery or be very pessimistic with the prognosis. The older age, and you know, when we talk about age of patients and old patients, young patients, it tends to be related to our own age. And as we get older, you know, what we call young gets older as well. But I think with degenerative processes around the hip, I think 40, 45, when you get beyond that, I think that the hip has a much reduced capacity for healing. Certainly dysplasia, I'll talk about this further, ligamentous laxity and femoral retroversion. So what about evidence in this regard? So this was a paper from a few years ago now, but again, they showed that basically the factors that were associated with failure of surgical treatment for FAI, again, showed older age, presence of arthritic changes, longer duration of symptoms, worse preoperative pain and functional scores. So the heart sink patient for me would be you know, the older lady perhaps, who's perhaps a little overweight, who's had symptoms for 15, 20 years, and they come in and they say, I'm so glad I finally got to meet you, because I'm sure that I've had pain for so long, you're finally going to cure me. And you know, absolutely, you cannot help that lady. What about arthritis? Well, there is evidence to show that there are worse outcomes if there's less than 2 millimeters joint space. But how do you assess OA? You know, I don't think we're very consistent at assessing OA. We can use different grading systems, but if you base it purely on the AP pelvis, you can miss a lot of osteoarthritis. I find that MR scans can be difficult really to assess level of degenerative change. They can certainly tell you about interosseous issues with cysts and things like that. But CT I do find to be much more helpful. They can show you joint space loss in all three planes. You can see cysts and osteophytes in these different areas. So this is an example X-ray. You probably say, well, this is certainly a little bit dysplastic, this hip. Perhaps there's a bit of subchondral sclerosis, maybe some osteophytes in the fovea, maybe a little bit of joint space reduction, but I'm not really sure. Maybe it's not so bad. Well, let's have a look at a CT scan. So you can see on a CT scan that in the anterior-superior area, there is bone-on-bone changes. And in femoral several impingement and often dysplasia, the damage occurs in the anterior-superior aspect of the joint, which is not tangential to any of the views on an X-ray. So the area of damage can be hidden by a plain AP and a lateral X-ray because you've not got a tangential X-ray. And here's another case. Again, you can see evidence of degenerative change on these X-rays, but the extent is underrepresented by the MRI scan. And when you have a CT scan, you can see that you wouldn't go anywhere near this patient with keyhole surgery. And you'd likely having a discussion with them about the appropriateness of hip replacement surgery if they were suffering significantly. So what about dysplasia? I've mentioned a couple of times already that I think it's really important to ascertain the extent of dysplasia in these patients. Certainly, dysplasia can occur at the same time as impingement from a morphological perspective, but it's a completely different mechanism of injury to the hip. Dysplasia is an instability problem, and that's worsened by ligamentous laxity. If they have femoral excess anteversion, which they often do, again, the femoral head can be uncovered anteriorly as well as laterally. Obviously, if they're overweight, that's an issue. And if they lose the core strength and hip girdle control, then symptoms can worsen. And the problem with hip arthroscopy with dysplasia patients is hip arthroscopy requires an anterior capsulotomy to access the joint and move the instruments around and achieve what you're trying to achieve. Now, you can sometimes be quite conservative with that, but other times it does need to be a rather large capsulotomy, which essentially you're cutting the ligaments that are stabilizing the hip joint, and you can produce further instability in these patients. There are techniques to repair the capsule or even reef the capsule, but these are quite advanced arthroscopic techniques. So I think the most important thing for us, that are seeing these patients is to really pick out these patients. So the most important thing is, I feel, is the lateral center edge angle. And you can see here that normal, as you know, is more than 25, borderline dysplasia 20 to 25, significant dysplasia less than 20. And this patient here is about 29 degrees. Now, I think the importance of doing this is finding the center of rotation. So you might look at this X-ray and say, oh, well, I think, this looks like the center edge angle to me, 27 degrees, that's absolutely fine. But actually, if you put a circle around the head, and that will tell you where the center of rotation is, and then you can do an accurate center edge angle. And actually, in this case, it's 15. So it's really quite sensitive to where the center of rotation is. And you can be fooled if you do it by eye. So I would thoroughly recommend using some kind of digital trauma CAD type system. Or if you don't have that, use an acetate with some Mohs circles. So these are just concentric circles printed on acetate, which you can hold over a computer screen or hold over a normal X-ray. And that will, you'll be able to line up that and see where the center of the hip is. There's good evidence that arthroscopy in the presence of dysplasia has worse outcomes when compared to femoroacetabular impingement. And these authors of this particular study suggested if you are going to do arthroscopy, then you should repair or plicate the capsule. Ligamentous laxity, again, in that mildly dysplastic patient, I do the Baton score in everybody because it's an instability issue. And again, the capsulotomy is going to increase anterior instability and potentially get further problems. So kind of my threshold about being worried about it is sort of 4 to 5 out of 9. So in summary, femoroacetabular impingement, you can get really good outcomes from surgery and you can get really good outcomes from physiotherapy. I think the X-ray assessment is really important. And in my experience, that is the bit which tends to get overlooked in treatment. And you really need to work hard to exclude the dysplastics and exclude osteoarthritis, because those ones, if you don't, they'll come back and bite you with recurrent problems. So thank you very much for listening.
Thank you, Tim. That was really informative and I think pretty precise in what we would like to hear in patient selection. If I can ask you a question that's been asked is, if you've got a patient with mild pain, a young patient with mild pain, and not significant changes on the labrum, but you can see the FAI, his symptoms are mild, would you counsel him to say that you can prevent osteoarthritis by doing a procedure for him?
No, I mean, my view on this at the moment is that we don't have enough evidence at all to suggest doing surgery on mildly symptomatic or asymptomatic patients to prevent something which may not happen. I mean, we've all seen patients, elderly patients that perhaps have come in with a fractured neck of femur who have a rip-roaring cam on the other side and a pristine hip. There's far more to the generation of the problem than just the anatomy. So I think it's a difficult subject because some people might say, well, if they've already got some symptoms, it's probably the process is starting. So I think it's hard, it's difficult. We will know more as time goes on. But at the moment, I don't think you can justify doing surgery on somebody that just has really mild symptoms.
Thank you. Another question is very much like when you do your FAI and you trim the bump, is there an end point? How do you identify when to stop? I think that is very much what the when people do a subacromial decompression, they say, when do I stop? Do you know when to stop? What's the answer?
Yeah, so I think you need to have good visualization of the neck distal to where you're trimming. So you really want to have a nice smooth surface right down into the femoral neck. You're not trying to create a really big divot. So there's a sort of the aesthetic of seeing that it looks nice and looks anatomical. We use X-rays intraoperatively, so you can get a good lateral X-ray of the area that you're treating. And you can take an X-ray before you start, and then during the procedure, you can see that you recreated a nice smooth concavity to the head-neck junction. And then finally, you want to do an on-table impingement test. So you might take the foot out of the traction boot and flex the hip up under direct visualization and see that you can get, to a good amount of flexion and internal rotation without impingement occurring. That can be difficult to achieve because the soft tissues tend to bunch up and you get a limited view when doing that. But I do always try and assess that intraoperatively as well. In terms of should you over resect or under resect? That's a difficult problem. We know there are studies showing that the most common indication for revision hip arthroscopy is inadequate resection of a cam at the first operation. The consequences of over-resection are obviously, potentially fracture. That's highly, highly uncommon, almost never seen. We did an FE study to show that you need to remove more than 30% of the neck to significantly increase the risk of fracture. And that's a huge cavity. So I don't think that's much of an issue. But again, if you over-resect, you might lose the suction seal on the head as well, and that might have some subtle consequences over the longer term. So probably always err towards being slightly more aggressive than under aggressive. But I think it's certainly a difficult part of the operation. I would say it's the most difficult part of arthroscopy is resecting a cam appropriately. Labral repair is much, much easier.
Wonderful. Thanks a lot, Tim. That was a fantastic presentation. If you can move on to Mr. Ajay Malviya. Ajay, if you want to load your first slide. Mr. Ajay Malviya is a consultant orthopedic surgeon at the Northumbria Health Care NHS Foundation Trust. He specializes in hip arthroscopy, sports injuries, periacetabular osteotomies. Mr. Malviya is fellowship trained in Cambridge, London, Switzerland, and was awarded this prestigious American-British Canada Fellowship. He sits on the British Orthopaedic Association Education and Careers Committee and the national lead of the UK Ireland Orthopaedic in-training examination. On behalf of the Northwest Education Academy, Ajay, I would invite you to start your presentation.
Thank you very much, Nikhil. Thanks for the invite and thanks for the kind introduction. So my talk is going to be on hip dysplasia, the management options. Clearly, Tim has covered bits of it, which is very helpful, actually. So if you're wondering where Northumbria is, well, it's in the northeast of England. It's a beautiful part of the country, and you're welcome to visit if you want. So what am I going to cover? So I'm going to talk about epidemiology of dysplasia, how to assess patients with hip dysplasia, which again Tim has covered a bit of, and the management. And primarily I'll like to use the concept of MIS, periacetabular osteotomy, and the evidence to support the management. So dysplasia, well, we very well know that it comes in various shapes and forms. Clearly one can have a completely dislocated hip, CRO 4 type dislocation, or it can be a CRO 3, and then the moderate dysplasias. So when we talk about hip preservation surgery, I don't think there are reliable hip preservation options for CRO 4 and CRO 3. So it's predominantly for moderate dysplasias where basically the hip is congruent. So this is one of the common questions asked: how frequent is hip dysplasia? Well, it depends on the kind of literature you look at, but most of the studies would suggest that actually it's between 5 to 10%, depending on the radiographic index that you want to look at. Interestingly, just because you have hip dysplasia does not mean that you will actually have pain. But clearly there are links between hip dysplasia and osteoarthritis. So imagine a lecture theatre full of people. So a significant proportion will actually have dysplasia. But clearly we are not going to be treating all of them. And not all of them have actually pain, including FAI actually. These pathologies are quite common radiologically, but certainly not all of them need surgical treatment. So what are the reasons behind it? I would say it can be because of environmental factors, spinopelvic alignment, and labral involvement. So with regards to environmental factors, I guess more and more people want to be fitter, especially in the middle-aged population. There is a vogue of starting running, engaging in various activities, and perhaps what that is causing is subtle abnormalities, which previously would have gone completely unnoticed, are causing problems, and the patients are presenting with pain earlier because the hip is perhaps not meant to do what they are trying to achieve. Another thing is the spinopelvic alignment. Well, the pelvis and hips, as you all know, it's a fine balance between where the spine is, and of course, the position of the spine will change the position of the pelvis and also the hip. So if the hip flexors are too tight, then the pelvis can retrotilt. If the extensors are too tight, then it can turn forward. So when it's turning forward in the sagittal plane, you can have almost an impingement type problem. Whilst if it tilts backwards, you can have a dysplastic type problems with actually the radiographic indices being all the same. And the last reason probably the patients are presenting is because obviously the labrum is getting involved. If the labrum is not involved, most likely they would not have pain. So imagine this mock-up diagram with the socket being shallow. And in this, you can see that the labrum is thick, and that's what happens in dysplastics. The labrum becomes thick to provide more support to the joint. And over a period of time, because of shearing forces, the labrum will get torn, and that's when pain actually starts. It has been shown that if you remove the labrum, the contact stress will actually increase by almost 90%. And this has led to the hypothesis that labral tear is probably one of the key occurrence in well-functioning dysplastic hips. And if labral injury does not happen, the hip may actually survive for a long, long time. So the study was done in Mayo. They followed up patients over around 30 years. Obviously, an award-winning study. They looked at the natural history of osteoarthritis in patients with hip dysplasia and impingement. What they came up was with regards center edge angle. The lower it is, especially if it's less than 25, the risk of progression from tonus 0 to tonus 3 or 4 OA or progressing to hip replacement is actually much higher as compared to when the lateral center edge angle is between 25 and 40. And clearly, if it's more than 40, again, the risk increases, and that was an impingement type problem. What about the tonus angle, the acetabular index? Well, if it's more than 10, again, the risk of progression of OA increases. So clearly, acetabular index and lateral center edge angle are key markers of assessing dysplasia, and they have relationship with the future development of OA. So again, other papers have also looked into the same thing, and what they've come up is if the center edge angle is less than 28, for every degree loss of center edge angle, the risk of having hip replacement over a period of time increases by almost 10%. So I think that's quite significant, actually. So how do the patients present? Well, no one will come with a label of dysplasia. They'll all present with pain, but with DDH in particular, they do have some degree of abductor fatigue. Sometimes they have IT band snapping. So if you're seeing a young girl presenting with abductor fatigue or clicking of the IT band, think about DDH. examination findings, standard examination findings, which I won't go through, but what is important is to assess the range of movement, to make sure that the degeneration is not set in, and always assess the rotational profile of the femur in prone position, because that will dictate whether you want to do something on the femoral side or not. Standard imaging, yes, X-ray, very important. You have to get it done. Role of MRI scan, I would say, is perhaps controversial in DDH, maybe to rule out osteoarthritis, but CT scan, again, brilliant investigation to define the morphology of the hip and to decide what you want to do actually. Tim has already covered center edge angle and acetabular index. The figure to look at is acetabular index more than 10 degrees indicates dysplasia, center edge angle less than 25 degrees, think of dysplasia, and look at the femoral head extrusion as well. But clearly, if you're getting a 3D CT reconstruction, you can see the problem, and it's brilliant to explain to the patients what the issue is, and they will understand the problem better, and they will actually buy into what you want to do. Acetabular version, yes, it's important to measure it. And again, everyone is well educated in measuring acetabular version, but what you want to know is where exactly in the coronal plane you need to measure it actually. So if you look at this picture on the right side, you can see that there are various slices, and in slice 2 and slice 3, in the next picture, just have a look at what the acetabular version is showing. So it's completely different. So which one is actually more relevant? Because there will be an error of measurement, and radiologists and surgeons will measure it at the various planes. So what has been shown is that slice 2 perhaps correlates best with the 3D CT scan. And 3D CT scan is the way to measure acetabular version, because that will correct the pelvic tilt, and that gives the more accurate assessment of acetabular version. But if you're going for 2D CT scan, slice 2 is actually better. Femoral version, you have to look at the knee as well to make sure that you have done an accurate measurement of the version. And again, standard techniques have been well described. And why do you want to know that? Well, McCubbin index, first described actually many years ago in pediatric literature. And it's a combination of femoral and acetabular version. And normal is 30 to 60 degrees. But if the femoral version and acetabular version in combination are more than 60 degrees, actually it shows severe instability. And if it's less than 30, it's actually indicating an impingement type issue. So the management will change depending on what the combined femoral and acetabular version is. So treatment considerations, what do you need to look at? Yes, you want to find out what the problem is on the acetabular side and whether there's a femoral side problem as well. Is it a congruent hip? You don't want to be thinking of hip preservation in CRO 3, CRO 4, because the results won't be reliable. You need to rule out arthritis, as Tim has already mentioned, even for FAI and dysplasia, arthritic patients don't do well. Asymptomatic patients, well, at least in my practice, I would not operate on asymptomatic patients. So treatment options, I've not included actually non-operative treatment or physiotherapy, because that goes without saying. Most of these patients would have had years of physio and of course analgesics and other forms of treatment. So when they come to you, they are looking at surgical solution. What your job as a surgeon is to find out what the problem is, and if there is a spinopelvic imbalance that you can correct by means of physiotherapy, yes, you should all have it. But then once all of that has been exhausted, these are the options. You can look at hip arthroscopy as an option, pelvic osteotomy. The various types of pelvic osteotomies for incongruent hip, Shelf and Chiari used to be performed in the past. I would say they have been consigned to history now. So the conventional treatment for pelvic osteotomy would be actually a PAO, or in some centers, triple osteotomies are being done. Occasional patients will need femoral osteotomy, depending on what the femoral problem is. And hip replacement, yes, in arthritic patients, and when everything else fails, that remains an option. So hip arthroscopy, Tim has covered it already actually, but yes, for severe dysplasia, don't think of hip arthroscopy for these patients, because it is going to fail. And for borderline dysplastic, there may still be a role if you're going for capsular plication and perhaps to deal with intra-articular pathology, perhaps to understand actually what is going on in the hip joint per se. Because in borderline cases, and in some cases, you're not 100% sure that you want to proceed with an osteotomy, and then you can actually have a look at the inside of the hip, look at the pattern of injury, and then decide whether they may well benefit from future PAO or not. And a traffic light system has been proposed by the Reading team, actually. So if you want, you can look at this paper. So what are the principles of any osteotomies? Well, if you look at this, you can see that there's femoral head extrusion. So what that will do is there is a smaller area of contact. And if the area of contact is small with the same force, the pressure will be high. So you want to correct that. You want to reduce the femoral head extrusion. You want to increase the contact area, and that will distribute the forces. And similarly, occasionally, you may need to do a combined femoral and acetabular osteotomy. The aim is the same: to restore the biomechanics, to increase the contact area and congruency, reduce the contact stress, and make the normal articular cartilage weight bearing. And that will hopefully help in regeneration of cartilage in the damaged area. So I've already said that there are various osteotomies. Triple is probably the competitor for Bernese PAO, but Bernese PAO is probably the most well-adopted procedure for hip dysplasia in the adults. And what is basically it? It is a periacetabular osteotomy, as the name suggests. You cut the ischium partially, you cut the pubis, you go through the posterior column and the ilium, and then the acetabulum becomes a free fragment. Posterior column is left intact, and that is the difference between triple and PAO. And because the sacrospinous ligament remains intact and doesn't come into play, the PAO allows a larger correction. And because the posterior column is intact, as you can see, the weight-bearing forces can go through there, and that will allow earlier rehabilitation. So yes, posterior column is intact. Large correction is possible because sacrospinous ligament would not stop it from correcting, whilst in triple it will. It allows joint medialization. Technically, it's perhaps slightly more demanding. And why is it demanding? Yes, the anatomy. So you need to have a good idea of the anatomy very well. You need to know where the vessels are, and indeed the nerves. The nerves are all nearby. So your dissection should be such that you always avoid it. So luckily, we've got the Psoas to help us. And if you respect the Psoas, if you are always lateral to it, and if your dissection is subperiosteal, the chance of actually damaging any of the major nerves and vessels is actually very small. Clearly, the lateral cutaneous nerve does undergo a bit of bruising, but most occasions tends to settle down. And your other friend is the II, use it all the time, and then it will help you get where you want to be. Special instruments, a standard osteotome or standard retractors won't work for this. You need radiolucent retractors. You need special osteotomes to make sure that the curves are all well respected during the dissection. So the traditional approach was the extensile Gans approach, and lots of surgeons probably still use it. This is the typical incision, and the mock-up diagram which shows where the scar would be. Look at the anterosuperior spine, look at the tensor-fascial artery and sartorius. The aim is to actually retract the sartorius muscle away, which is what been done after an anterosuperior spine osteotomy. And slowly you will start to see the rectus femoris, you will see the iliacus muscle, and then you again go into that plane, retract the iliacus medially, and then you'll be able to see the hip. And this is where you would approach the ischium underneath the hip capsule. All of this can now be done via minimally invasive techniques, actually. So the approach can actually be quite small. You lift the abdominal muscles, the inguinal ligament, and the sartorius in one plane, and you use this plane to just go inside the pelvis. And the dissection, deep dissection, is actually very similar, but obviously the anterospheric spine remains attached. The rectus femoris muscle again remains attached. So you are going intramuscular, you're not damaging muscles, you are actually respecting the soft tissues better with MIS approach. And then just underneath the capsule, you look at the ischium under the X-ray control, and using, as I was saying, special osteotomy with well-defined curves, you start doing the ischial cut. You don't cut the ischium fully, it's half a cut. And again, the X-ray will guide you with it. The pubic osteotomy is actually pretty straightforward. It's done under direct vision. You can see it. And then the posterior column cut, again, under X-ray control. And you can see that the osteotome there is right in the middle of the posterior column, between the acetabulum and the posterior edge of the posterior column. So you complete the cuts, and then you start taking the ileum down with a saw. And once the lateral part of the ileum has been taken down, you use another osteotome to make further cuts between the ileum and the posterior column, so that everything combines. You put a Schanz pin in there, and there you go. The acetabular fragment becomes completely free. And then you fix it with a few screws. And all of this using an MIS technique. Clearly, it needs experience. It needs respecting the soft tissues. You do need help initially, but after that, once you start becoming more and more experienced, you can actually take on very complex cases. So the difference is actually quite significant in terms of the scar. In the traditional approach, you can see that the scar used to be massive, and especially this part of the scar would not heal very well, while the MIS PO scars heal very well. So it's a particular advantage, especially in young females, having a cosmetic scar, because they are very mindful of it, actually. It avoids alteration to the lateral cutaneous nerve territory in majority of the cases. Because there's minimal dissection around the hip capsule, the pain control is better, the mobilization is earlier, the length of stay is actually reduced. And again, this has been well proven. Yes, blood loss is much less, overall complication rate is much less. In this particular paper by Sobal, he initially was using the ilioinguinal approach and then moved on to an MIS approach and found that the arterial thrombosis rate changed from 3% to 0. So quite significant. You don't want femoral artery thrombosis when you're doing PAs. So certainly MIS approach is better. In terms of joint survival, very similar, probably MIS slightly better in Sobal's series, but he agrees that it's probably because of better patient selection. So this is fresh off press. Some of you are probably aware of the non-arthroplasty hip registry in the UK. We collect outcomes of non-arthroplasty procedures. Most high output surgeons actually enter the data in it. And we've got around 12,000 odd procedures in the registry. And out of those, more than 1,000 are pelvic osteotomies. And as I said, this is fresh off the press. This report was published a couple of days ago. And you can see that the IHOT scores and the EQ5D scores after pelvic osteotomies improve. And quite a lot of improvement at 1 year, and this improvement continues beyond 2 years actually. And if you look at the age distribution, again, and from the current report, what you can see is in all age groups actually, the pain scores improve. But if you're doing it beyond the age of 50, and there are a few patients you can see between the age of 50 and 60, the results after 1 year are probably not that great. So you need to be careful about your age criteria. Lots of independent center studies have been done after the initial reports from the burn unit, and they do show good long-term results in terms of joint survival. And we've got 20 and 30-year results from the originating centers as well. There are clearly contraindications. You should not do it in patients with arthritis. If you're doing it in early OA cases like tonus 1 and tonus 2, again, the chance of survival just reduces. So you need to counsel the patients appropriately. There would be complications. There are complications. And in this series by Centauri, the systematic review by Centauri, he had looked at major bleeding rates, sciatic nerve palsy, and the posterior column fracture rate, etc. And yes, these are there. And there are ways to reduce it. And these are probably the most common complications. Non-union of the pubis is again quite common, but it does not typically affect the long-term results as such, because if the rest of the osteotomy heals, then the weight-bearing forces are actually fine. Again, Centauri's paper had shown that the complication rate reduces depending on the numbers you've done. They would recommend that if you're not doing it more than 20 times, perhaps you should not be doing it. So the Centauri paper is quite old. So we've done a recent systematic review of more than 4,000 patients, which shows that the major complication rate is around 7%. But with MIS approach, it's actually much lower. So my own personal series, I've done a fair few, and I would say no major nerve injury, couple of patients with L5 dermatome, paresthesia, some deep infections in high BMI patients. And yes, stress fracture of the posterior column is probably actually more common than has been reported. I would say around 4 or 5 that needed actually formal fixation of the posterior column. So that is related to early rehabilitation, related to high BMI and older patient where the healing capacity actually reduces. Functional outcomes, yes, we record it all the time, and these are the 5-year outcomes, quite a good satisfaction rate at 5 year, I would say. So in summary, we've gone through how to assess patients with hip dysplasia. We've looked at the epidemiology. We know that with PAO, good functional results will be achieved, and there's reasonable mid to long-term survival. If you're using MIS approach after good training, the complication rate is low. You have to look at the femoral side as well, and there are procedures that may need to be done on the femoral side depending on what the problem is. Patient selection, very important. Age more than 40, you need to have a serious discussion with the patient whether they want it done or not. If you're doing it in arthritic patients, again, you need to be extremely worried. Thank you very much.
Thank you, Ajay. That was a very thorough presentation. And for some of us arthroplasty surgeons, it is an eye-opener. So thank you for reminding us on what else can be done. There is one question, Ajay, which is on how successful are we at preventing the need for total hip replacement by doing periacetabular osteotomies? And I think you've answered the second part of it in some way, which is operating on patients with mild symptoms advisable?
Okay, so if you have a patient who's under the age of 30, then you can expect 90% survival at 20 years after a PAO. So I would say that is good. If you look at all age groups from the Bernese group, the results that they had come up with was at 20 years, and that's the original series that they had presented that done in the surgery, which was in mid 80s. So that 20-year result was around 65%, but that's for all age groups. So the ideal patient actually is someone who's under the age of 30 who doesn't have OA, and in those cases you'll actually expect very good results.
And would that be with mild symptoms as well, or do you need to see multiple significant symptoms?
Okay, so I'll always be worried about operating on patients with mild symptoms. They need to have enough pain to have the operation. I don't think 6 months, 1 year, 2 years matters as much in the younger cohort. Yeah, but mild symptoms, no, I wouldn't offer it to them.
Fantastic.
Can I ask a question?
Yeah, absolutely. Go on.
Yeah, Ajay, what do you do for these patients between 20 and 25, center edge angle, which you deem is not suitable for PAO, but they have labral tears and persistent pain. Do you consider hip arthroscopy repair? And if you do repair a very thick labrum, any specific tips?
Okay, so centrage angle between 20-25 or borderline dysplastics, you need to look at the overall morphology as well. So do they also have the impingement type problem? And if you can actually see a decent going cam, especially in males, you probably will actually, then I'm more confident that arthroscopy will probably work. When there isn't any cam at all, then I would be extremely careful. I would counsel the patient that, look, it might well be that we will probably go in and have a look, repair the labrum, and it may well be that you will end up needing a PAO in the future. So yes, I would counsel the patients. Then there are other things that you need to look at as well. So for example, if there's a hyperlapse patient with Baton's 9, for example, or more than 6, again, I would counsel them against a hip scope. I will have probably a lower threshold of proceeding to a PAO in that group rather than thinking of hip scope, because I think the results with borderline dysplastics in young females are actually pretty good. Whilst the results of hip arthroscopy in the same gender group, in the young female, I would say actually are not brilliant. And the reason is we've missed dysplasia. Also look at the relationship between the anterior and the posterior wall. Sometimes centrage angle and the acetabular index seems okay, but you'll see that the anterior wall is actually quite medial. So they've got focal anterior dysplasia. So in that group, again, it's not worth trying a hip arthroscopy. With regards tips to management of the labrum when the labrum is thick, once you see a thick labrum, yes, worry about dysplasia. And sometimes when you do hip scope, you'll realize that the space is very tight. So it's not an easy arthroscopy in dysplastics anyway. So you have to really, really be careful and be away from the labrum as much as you can. Try to establish portals gently. If you're meeting resistance, then of course you are through the labrum. And sometimes you do go through the labrum and then re-establish the portals. And then once you've done the dissection, it becomes easier. The hip opens up more, than you are able to see it better. But yeah, thick labrum, always a bit of concern.
Thank you a lot, Ajay. Thanks for that. We've got some very interesting cases. I think we'll have about another half an hour or so to go through them. So if I can introduce Mr. Prakash Chandran. Prakash, you want to put your first slide on? Mr. Chandran is a consultant orthopedic surgeon at Warrington and Halton Teaching Foundation Trust. He has keen interest in primary and revision hip replacements, does a lot of hip arthroscopies, and has numerous publications and presentations. We'll go through cases, and Prakash will involve the faculty as well. Go ahead.
Thank you, Nikhil. So I've lined up a series of cases. Depending on the time, we will probably go through them. So we will start with a straightforward, commonly seen case in the day-to-day practice of hip, and I'll take through the presentation, and then we can discuss, how we go about managing them. So the first case is a 32-year-old male who comes to the clinic, has a significant or insignificant rotational injury, can remember the injury, but it doesn't attribute it to be a major injury. This was 3 years ago, but since then he is having pain, particularly in the groin, very focused, intermittent pain, sometimes so sharp that he has to stop doing what he's doing. When he's not in pain, he's fine, he can carry on doing most of his normal activities. So it's a typical young person with groin pain. Now, the first question is, when we see him in the clinic, I think I'll get Mr. Board to answer this question. When we see these patients in the clinic, Mr. Board, what are we actually focusing on while we are examining? And what is the investigation sequence for these patients? Do we go with because from your talk, we know that, there are a set of investigations we can request from X-ray, CT, MRI, arthrograms. So what is your take on, these investigations? Do you go for all of them at once, or do you go in a certain sequence?
Yeah, thanks, Prakash. So I think that the examination for me focuses on, when you call the patient from the waiting room, visualization of gait in these patients is really, really important as a first thing, really. I would expect this guy's gait to be completely normal. It sounds like he's somebody who's only really struggling, intermittently. But, I'd want to know his balance, Trendelenburg. I want to be able to probably asking him to do a single leg squat. I think that's a good indication for, truncal control and stability around the hip joint. They're often, the rest of the examination could be quite normal, but, they can be just really unstable when trying to do a single leg squat on one side. So that's something I kind of picked up from our physios as a good assessment for, hip girdle control. When I've got him on the couch, I guess one of the main things I'm looking at is the, any structural abnormalities. So limit discrepancy, rotation abnormalities. Are his feet, is one side, in external rotation? Does he have squinting patellae? So I'm starting right at the very bottom, looking at the tibial torsion, femoral version, and then, going on to sort of the more kind of routine range of motion testing. And I would expect with this guy that he's likely to have some pain and flexion of that hip beyond 90 degrees, and then that be exacerbated by internal rotation with a bit of adduction probably, and probably not very tender in external rotation. But sometimes they do still have a fair bit of discomfort on all hip ranges of motion. And I think he probably would likely have quite a, if he's got impingement, which is probably what's happening here, is that he would have a reduced range of internal rotation. So he might just have 10 degrees of internal rotation, maybe he's got 20 or so on the left. But if this gentleman had, for example, 30 to 40 degrees of internal rotation on his affected hip, I would be immediately thinking dysplasia. As AJ mentioned in his talk, they typically do have a greater range of rotation in flexion than the impingement patient. So I think that's an important sort of warning flag, that you want to be thinking about that if they've got significant internal rotation.
And the investigation sequence for these patients, do you get the x-rays first in the clinic, then request the scans, or do you request all of them at one go?
Yeah, I would absolutely get an x-ray in the clinic if they don't have the one already. I certainly wouldn't send them off and get all of those things because every now and again you will have a patient that an x-ray tells you all of the answers you need. And there's no need for any further investigations. If they've got significant osteoarthritis, or maybe they've got significant dysplasia, and actually maybe they need to go to see somebody else, or they're going down a different route of treatment. So yeah, I would do a plain X-ray in the clinic, and then on the outcome of that, depending, probably if I think that they're a patient that's heading towards arthroscopy, we would normally do both MR and CT. And in terms of the CT, I think as AJ mentioned, we're really interested in the rotational profile. So CT of the hip, but including slices through the femoral condyle, and then maybe even slices through the ankle as well, so that you can assess the tibial and the femoral version on both sides.
Okay, yeah, thank you. Tim. So next, I think I'll ask Mr. Bonshahi the next question. So we have X-rays and NMR arthrogram. Now you're seeing this patient again. Obviously, symptoms are continuing. So the question to you is, what do you look for in these images, and what is your trigger to discuss surgery with the patient?
I think on the MR scan, I would look for any signs of arthritis. So I have a very, very high threshold in offering patients hip arthroscopy, and this you learn through trial and error from the initial exposure. And you find that even patients with subtle arthritic changes, for example, a cyst on the acetabulum or cyst on the femoral head, you wish to avoid doing hip arthroscopy if possible. Now, this chap has got a large cam lesion, and from these two scan images, you can't really see any cystic degeneration, but I would go through every slice in the scan, looking carefully for that. You also, in some scans, can pick up acetabular laminar delamination of the cartilage. You can pick up sometimes in a good quality scan. And those are, often poor indicators for poor prognostic indicators. Probably the best next investigation for this gentleman would be a CT scan with 3D reconstruction, so that you can map out the cam lesion, and actually your joint space assessment is better on a CT scan than the MR scan.
And what is your trigger for discussing surgery? When do you kind of say, okay, now we need to start thinking about surgery?
I mean, they should have gone through all the conservative measures. If he's very symptomatic, I'm happy that there is no significant arthritis, then I will consider them for surgery. I mean, in this gentleman, in this image in the middle, there is a suggestion of a labral tear, but you can't see the dye going through and through. So you got to see what is causing him the pain. Is it arthritis, labral tear, and rule those conditions out?
Okay, yeah, thank you. So next I'll probably ask Mr. Malviya for the sequence of plan. So arthroscopically, obviously this gentleman has got a labral tear and a cam lesion. What is your sequence of addressing these? Do you start with the central compartment, or do you start with the peripheral compartment? Do you do the labrum first or cam first? What is your take on it, Mr. Malviya?
So clearly there are various approaches, as you are alluding to, but my personal approach is, yes, central compartment first. And if the hip is distracting easily, you get the kind of space that you are showing in the image, then yes, central compartment, you have a diagnostic round, you find out where the problem is, which bit of the labrum is unstable, which bit of the cartilage is unstable, and then you go behind the labrum in the paralabral sulcus area, clear the rim, and see if the rim is prominent anywhere, trim it a bit, and then repair the labrum, and then deal with the cartilage lesion, again depending on how it is. And then you proceed, you release the traction, then you proceed with the peripheral compartment and take the cam off. Now, some of these, especially young males, sometimes distraction is very difficult. In all my patients in the past, there was various types of anesthetics that were used, but in all my patients, they are getting a combination of spinal anesthetic and GA with muscle relaxant. So most of them, the hip would open up. But when the hip is not opening up despite that, then yes, I would do peripheral compartment first, take the cam off, and then do a bit of capsulotomy. And again, in most of them, once you've taken the cam off and done a bit of rim trimming, then the hip tends to open up, and then you can go safely into the central compartment and address the pathology.
Yeah, so, and the next question is, after you've done the procedure, so you've taken the cam, we've repaired the labrum, dealt with the cartilage, what is your post-op plan? How do you manage these patients post-operatively? When do you start them to?
We do have a standard physio protocol. The first phase, for the first 4 weeks, I always give them crutches. I don't allow them to do too much. And I say partial weight bearing. Some of them do get rid of the crutches, but it's just to remind them that something has been done. Because the worst that can happen with these is they tend to overdo things, and then they come back with problems. And I think over time, what has been proven is start slow, gradually build up, and then do things. Most of them, I do suggest that in the first 4 weeks, yes, range of movement is good. Obviously, weight bearing is protected. And then once it starts to heal, the labrum starts to heal, and then I would let them get rid of the crutches. And of course, the physios are looking after them, actually. So they are the ones who are suggesting what the next step would be for them. But yes, for the first 3 to 4 months, I would avoid impact activities like running, etc. But after that, once the hip is healing well, they can progress to that.
Okay, thank you. So this is a kind of a common case scenario which we kind of face in a day-to-day setting. So the next case, I'll move on to the next case because I think I'm conscious of time. This is a case where you have groin pain post hip replacement. So we'll discuss this case through the sequence, and then we can see how we address groin pain post hip replacement. So this case, is a 70-year-old lady, had a uneventful total hip replacement. But 3 months post-op, she developed pain in the groin. And this is a new onset pain. It's not similar to the pain which she had before surgery. And the pain got worse and she was unable to walk even 500 watts. And she was very upset that, the surgery is not working. She cannot carry on with her normal day-to-day function and her hobbies. And she always felt the surgery was never right and I'm not happy with it. Typically, the pain was different to the pain she had before surgery. And she had pain in flexion, when you go up the stairs or when you're getting in and out of the car or when you're getting in and out of the bed. Assessment-wise, a good passive range of movement, pain on active flexion, palpation, there was a mild tenderness in the groin, and the Psoas provocation was positive. Now, at this stage, I would like to ask Mr. Board, what do you do next? How do you go about managing these and kind of evaluating and making an algorithm of what to do next?
Yeah, so I mean, from the presentation here, this does sound very much like a psoas irritation case, but as Adi said in his presentation, it is to a certain extent a diagnosis of exclusion. So it's highly important to rule out infection, loosening, and other causes of pain, back issues, and things like that. So thorough investigation, examination of the patient is obviously vital. But often, in my experience, these patients have already been through that mill quite significantly, and they've been maybe to a number of surgeons and have had significant investigations. And by the time they come, it's already pretty obvious that this is probably what the problem is. So the investigations would be, as you put it there, plain X-ray, and sometimes there can be subtle signs on the X-ray that maybe it's a psoas problem. A very lateralized socket, a socket which is very large compared to the other side, perhaps retroverted, and CT scanning is definitely the most useful investigation. Axial obliques with, as I said, reconstruction in the plane of the femoral neck that you've mentioned there really allow you to see the anterior aspect of the socket in relation to the anterior acetabular bone. And then really the ultrasound guided injection around the psoas tendon sheath is really a diagnostic test. If they don't get a response to that, and they don't have CT proven uncoverage, and they don't have the classical symptoms, those sort of 3 tests really, then I wouldn't be confident to offer that patient a surgical intervention. But if they do tick those 3 boxes of the classic symptoms and examination findings, CT scan positive and ultrasound positive with injection, then in my experience, they've been really a happy group of patients to have a psoas release.
Okay, so I'll put up the X-rays for this patient. I just wanted your kind of observation on this. So that's a plain X-ray of pelvis AP, and I've got the focused sequence of the hip AP and lateral. So can you just highlight us what you are kind of looking at and what can you actually pick up from this?
Yeah, well, what you can see here, obviously, this is a cemented acetabular component. There's a very, very thick medial cement mantle. The socket is somewhat lateralized. Laterally, there's some cement escape. The cement escape posterior inferiorly and medially into the obturator foramen. So there's probably been a general cement escape around this acetabulum. It's the kind of the lateralization or the lack of medialization of the socket again implies maybe the socket itself is quite proud laterally. I think the lateral X-ray there is really very difficult to see, to comment on, but sometimes it certainly can show a degree of uncoverage at the front.
I think I've got a CT scan as well, so probably the CT scan is the sections in there, so you can see a bit better on these.
Yeah, that's right. So I find it, we've got, when you look at the CT scans, you can bring up 2 separate images and use the cut lines to actually work out exactly which axial section you're looking at in relation to the coronal section, because you can clearly see in this one that there is at the front of the hip there, you can see there's significant uncoverage and cement coming out the front there. But it's important that if you see that's in a relevant part of the anatomy, because if you see that really anterolaterally right at the top, that's not going to cause you psoas impingement. So the uncoverage has to be seen in the area of the psoas groove, which is kind of the area from the center of the head and a kind of inferiorly from there, kind of about a third of the way down. So in that general area of the psoas groove, you want to make sure that you're looking at the axial slices in the relevant section rather than just kind of anywhere around the hip. But this case clearly is showing that.
So what do you do next? When you see this and patient is there, what's your next kind of sequence of management plan?
So I think, so if this is a patient that's had an injection already and perhaps had a good response from that, for a couple of weeks, is that where we are now?
So ultrasound guided injection has been highlighted, and physiotherapy. So 3 months review, the injection response improved only for 2 weeks. The pain levels have gone back to what it was before the injection. So when do you kind of think about maybe this is a candidate or patient would benefit from intervention?
Yeah, well, I mean, I think that's the time to discuss that now, really. I don't think there's any benefit to be had from repeating that injection. So you had improvement for a short period, but often they describe that as a significant improvement from that time. And then I would discuss, what they wish to do. Now we know what the problem is. Do they want to proceed with an intervention, or are they happy just to understand their problem and move on? But if it's a surgical intervention, then I would talk about, arthroscopic tendon release or revision surgery. And in this case, obviously, she had an arthroscopic tendon release. And when you talk about risks of surgery, most patients, don't really want to entertain the thought of having a revision operation. They're quite happy to think that actually, a keyhole surgery to release the tendon, that kind of makes sense. The data, the evidence that we have suggests that there's a good outcome, and the recovery is relatively quick. I do worry about revision for these cases, because I think in a number of cases, obviously you're removing a well-fixed implant, and you can cause significant bone loss by doing that. It may already be a case where the surgeon has over-reamed the anterior wall, so you actually have missing bone, and you can revise the hip, and you still can't get the new socket to be covered by bone. So you haven't really achieved anything. So I think you have to be cautious about assuming that somebody with a significantly uncovered socket can be cured by revision, because there may be missing bone. And the surgical intervention of arthroscopy is so much more straightforward and minimally invasive and less comorbidity, less risks for the patient, that it's worth entertaining that certainly as a first step. You're not going to burn any bridges other than having cut the tendon.
I think in this case, there was a piece of cement which we had identified in the CT scan. It was in the anterior aspect, which was removed, and the psoas tenotomy was done. That was a piece of cement.
So I mean, just obviously showing that image there, but the mainstay of treatment is the psoas tenotomy. It's not removing fishing bits of cement out there. Main bit was to do the tenotomy to decompress the tendon. Post-operatively, I think the advantage was there was no additional precautions needed for this, and you encourage full weight bearing and passive and active range of movement. Yeah, that's right. So they do tend to recover very quickly. And if you've got the diagnosis right, they do notice that the pain is dramatically reduced within a few days of surgery. In the majority of cases that I've done, and long term, they do seem to do quite well. Yeah.
Yeah. So this patient, you're right. This patient exactly, within days, the pain was completely gone. She was quite happy. At 1 year, she was back to what she was, wanted to do as a good outcome following hip replacement. Just one last question, how do you think, while doing primary hip replacements, what should the surgeons be kind of conscious of, so that, we don't end up being in a scenario where the psoas tendon is getting irritated? Any tips you want to give to the surgeons?
I mean, I think the main thing is to be aware that it's a problem. To think about the psoas when you're putting in the socket. we say, making sure there is bone cover to the front of the socket all the way from 12 o'clock to 6 o'clock, to run an instrument around the front of the socket and make sure you can palpate bone all the way along the front, particularly in the psoas groove area. And you need to check that, when you put the trial in, and check that when you put the definitive implant in as well. And the other point which to kind of highlight here is that, in terms of the cut reaming technique, so the acetabular fossa is quite frequently not in the center of the acetabulum in the anterior and posterior plane. So if you use a very small reamer engaged in the fossa initially to ream out, and then use sequentially increasing sizes, the subsequent reamers will always engage in the previously reamed area unless you're actively, changing that. So it's quite easy if you have that technique and you're not really concentrating to over ream the anterior wall, and then suddenly you've lost bone and then you can't get coverage. So, I tend to start with a somewhat larger reamer. So I would template the size of the socket and start with a reamer 2 to 3 sizes smaller than that, so that it's engaged within the true acetabulum rather than within the fossa itself. And also just not using a socket which is too large. There's good evidence now that if you use a socket more than 4 millimeters larger than the head size, then the risk of groin pain is much higher. There's a couple of papers on that one. We published a paper on that recently as well. So I think, being conservative with the reaming and just being aware of where the anterior psoas groove area is, and you can avoid it.
Great, yeah, thank you. That's a very, very good tip for the surgeons who are preparing the acetabulum to see how you're reaming, whether you start with a small reamer and get it bigger, or you go for a bigger size depending on your head size. I think you have to be very careful of, not going too posterior or anterior. It's a very good tip. Thank you.
Can I make one other point, Prakash, around, psoas tenotomy? I think a lot of people might think, if you're cutting the psoas tendon, they're going to get terrible weakness afterwards, and that's always going to be there. That's true, but actually all these patients have massive psoas weakness beforehand. None of them can engage their psoas beforehand. And I, when I've spoken to patients, both before and after surgery, I always ask them, how's the strength of the hip? And they've all said to me, it's stronger than it was before. Maybe it's a little bit weaker than the other side, but it feels much stronger than it was before, because they can engage their other hip flexors. Whereas beforehand, if they try and do any hip flexion, they're all shut off because they get psoas pain. Whereas afterwards, they can engage all the other hip flexors, but they just don't have a psoas. So they are stronger than afterwards, but they do have some residual weakness. So it's an important thing to discuss with the patients.
Yeah, thanks, Tim. That's a very good point, isn't it? Even though you're doing a tenotomy and defunctioning parts of the muscle, you're still not losing the strength. In fact, you're actually gaining more strength because you're recruiting other muscles in. So that's a very good point. Thank you. Thanks, Tim. I think we'll move on to the next case now. Once again, this is a case of groin pain post-hip replacement. We'll just look at it and see how this is different to the previous case. So this is the story. Is a 40-year-old lady had a hip replacement around 5-6 years ago. Groin pain worsening in the last 18 months, particularly catching and locking symptoms felt in the groin. And when it happens, it's really painful, like sharp, excruciating pain. And she finds difficulty to get into the passenger side of the car, but not on the driver's side. So you can see the difference in the movement, which causes to get her the pain. Clinically, she's on the overweight side. Gait was normal, leg lengths were equal. There were tenderness in the groin, around the groin, difficult to focus on the area. There was weakness to lift the leg in the seated position, and there were no other specific signs. So these are the gross findings. So X-rays, these are the X-rays. I just wanted to now ask Mr. Bonshahi, what do you see on these X-rays, and what is your next plan of action for this patient? And what are you thinking in mind? What could be going on?
Yeah. I mean, from the history, it is very suggestive. Again, like the previous case, it sounds like a psoas type pathology. And it's very interesting that her left hip is giving her difficulty in getting in through a passenger side of the door of the car. And I assume, as the patient sits, then they have to lift their left leg into the car footwell And that's where the difficulty comes in. Whereas if you enter from the driver's side, you don't have to flex the hip that much with the left leg. These x-rays, obviously, it shows a cementless hip. It looks a bit long, very low neck cut, big, very open acetabulum, and a femoral head with a skirt. I don't, use the skirt ever. So I assume, this patient has had some sort of instability on table, which is why they have tried to lengthen and use this device there. So you have to rule out other abnormalities, like in my talk, you have to rule out other problems with this hip and not just jump to psoas as the cause of the pain.
So what do you do? What would you be your next kind of investigation?
So I'd run the patient through a complete, investigation profile, bloods to rule out infection, then probably further investigations like an MRI scan, Mars scan, to look at what is going on there. Lateral X-ray we've got. I'd like to see the full length of the femur X-ray as well, because we're missing the tip there.
So there you go. So she had an MR scan of her hips, and she also had a bone scan, which was a normal painful hip replacement workup. It's being done. Now, if we look at the MRI, there was fluid collection around the periprosthetic area, mainly in the anterior aspect. It was lobulated adjacent to the neck and the psoas tendon area. Other investigations, CRP, ESR, cobalt chromium levels, aspirates, they were all more or less normal. There was no evidence of any infection. So what is your next step on it? How do you then go about identifying or excluding the psoas pathology, or is there anything else you would be considering?
Yeah. I think that amount of periprosthetic fluid collection is quite extensive, and I've not seen this amount of fluid around a psoas patient before, really. So I would be thinking, is there something else wrong with this hip? And in particular, because she's got a skirt around the neck, I'll be thinking about, is this metallosis? We've ruled out infection with the, can you go to the investigation slide again? So the CRP is normal. The hip was aspirated. No growth was noted. So, we ruled out infection effectively. Metallosis should be a consideration. And if everything has been ruled out, then one can consider this being related to the psoas tendon.
So how do you go about then confirming or kind of ruling out that it could be?
I think I would organize the interventional radiologist to do an ultrasound guided injection to see if it takes away the pain.
Okay, yeah, okay. So based on the outcome of the injection, then you would plan for your next sequence. Okay, yeah, thank you. Thanks. I think I'm very conscious of time now. There's one more case. It's a quick case. We'll just discuss the case. I'll make it as the last case, okay? So the case 4 is a young person, 32-year-old lady, right hip pain, groin pain. She had pain in the groin for a few years, and then she had a baby. After the baby, she got more pain, which is mechanical. Otherwise, she's quite fit, active lady, involved in sporting activities. Clinically, she had internal rotation of 20, external rotation of 40, and pain on extreme range of movement. These was the positive findings on the observations. These are the x-rays. I would like to call Mr. Malviya to see how he would kind of interpret these x-rays and what is his next sequence of plan for this lady.
So looking at the imaging, what we can see is the acetabular index is probably raised. And if you measure the centrage angle, I think it would be reduced. The joint space bilaterally seems to be fine. On the left side, actually, there is some labral calcification suggestive of obviously pressure around the labrum and maybe a labral tear on the left as well. But I believe her symptoms are on the right side. The rest of the hip looks to be fine. There's a bit of valgus of the femur, so I would be slightly worried about femoral version issues in her. In terms of...
So we organized the MR and the CT scan.
Yeah.
Can you take us through, what you are kind of looking at and what is your thought process?
So what I can see on the MRI scan is a very thick labrum and quite a significant acetabular cyst. Clearly, this lady is developing OA. And even on the CT scan, you can see an acetabular cyst which is communicating, it seems to be communicating with the joint. So I would be worried about hip preservation surgery in her case at the age of 32. Obviously, that's what she's been referred for, I guess. And
Yes,
then,
yeah.
my standard protocol would be, has she had an injection, which I would normally organize to make sure that the pain is relieved. Her range of movement seemed to be pretty good, though. In someone who's developing arthritis, you would find more restricted movements than in her case. So if I want to do a PAO, for example, for dysplasia in her case, then perhaps either better quality MRI scans or even a hip arthroscopy to see if the acetabular cyst is communicating with the joint or not.
In this case, obviously there is an element of dysplasia, there is an element of labral pathology, and also there are some cysts in it. And she's quite a young person. So what is your sequence of addressing this? Do you kind of go for a arthroscopy first, or you think that dysplastic hip needs a PAO, you plan that at the same sitting? What is your sequence of addressing that?
So my threshold for treating these has changed over time. So typically, this would probably be a contraindication for PAO now, I think. But in the past, I've done hip arthroscopies to assess them, mainly, as I said, for diagnostic purpose. So I would probably do that for her to see if the joint is in a good enough condition to think about PAO, because we do know that acetabular cysts are a very common finding in dysplastics. And typically the acetabular cysts, we do again know that after realigning the socket, they tend to resolve and get better on their own without us doing anything. So with that thought process, I would do an arthroscopy. And if the joint is fine, then a periacetabular osteotomy given her age and good range of movements.
Yeah, I think you're right. Probably that's what we was done. So she had an arthroscopy to check how damaged the labrum is and what is the state of the articular cartilage. Is that cyst indeed communicating? Is there a big flap, a lot of bare area? And I think in the arthroscopy she had reasonable articular cartilage intact, and there was no communication through that. So the decision was made that she probably would benefit from realigning the acetabulum. Periacetabular osteotomy was done, and she has done well after that. So this was a few years down the line. You can see the head is now covered more than what it was, almost down to the edge. The osteotomy itself has healed well, and she is quite happy that her symptoms have settled down. So yeah, you're right. Depending on how bad or involved the articular cartilage is, would dictate whether you would want to go for a hip preservation or you want to consider some kind of an arthroplasty type procedure. Good, yeah, great. Thank you. I think we are running out of time. I'll probably stop here and hand it back to Mr. Pradhan. I would like to thank all the speakers now, but I'll let Mr. Pradhan take over from.
Thanks a lot, Prakash. Thank you. So once again, thank you all of you for sparing your Sunday morning time. I can understand it's family time, but really, really kind of you to give us time. And thank you for your cases. Hope you have a good Sunday evening. And thank you once again, all of you.
Thank you.
Thank you.
Thank you.
Ravi, has Nikhil left as well?